The case today involves an anterior tooth, in this case tooth number 8. This patient presented with a history of an extraction of tooth number 8 approximately 15 years ago following trauma, and since that time has been wearing a removable prosthetic flipper to replace tooth number 8. And he is interested in an implant to restore the architecture and the contours of tooth number 8 without the need to have a removable prosthesis. One of the challenges that we faced with this patient was the fact that he has been living without tooth number 8 for a considerable amount of time, which has caused some blunting of the papilla between 7 and 8 and 8 and 9, as well as a moderate buccal defect, as you can see there. First thing to do in the process is to try in the prosthetic stent to confirm the fit and the orientation of the proposed osteotomy site. And this is done with the periodontal probe, gently probing around. Once we've confirmed the fit and the alignment of the proposed osteotomy site, topical anesthetic is applied and local anesthetic delivered both to the buccal and to the palatal tissue to ensure patient comfort. Generally want to anesthetize the area 2 teeth, mesial and distal, to the proposed osteotomy site, as this will be important when the time comes to reflect the flap as well as reapproximate the flap in the future. A full thickness mucoperiosteal flap is developed utilizing a sulcular incision, and the incision around the osteotomy site is made slightly mid-crestal to slightly palatally. Again, great care should be taken with development of the flap to protect the soft tissue architecture that already exists and to ensure no laceration of the tissue. Once the incisions have been made, the tissue is bluntly dissected back utilizing the blunt end of a periosteal elevator in this case. Again, extreme care must be taken so as not to damage the flap itself or compromise the blood supply in any way. Once the buccal tissues have been released adequately, a small incision can be made around the lingual of the teeth on either side of the proposed osteotomy site, again being cognizant in this case of the incisive canal between 8 and 9. Gentle pressure is applied to reflect the palatal tissue. The prosthetic stent is then reapproximated and the initial drill is placed. Confirmed once the prosthetic stent is removed, utilizing the pilot drill just to reorient the alignment slightly. And the osteotomy is expanded and developed fully utilizing the subsequent drills. In this case, the decision was made to place a 3.7 by 11.5 millimeter implant. And once our initial 2.3 drill has been completed, it's placed in a periapical radiograph taken to verify the location and position before the 2.8 final drill osteotomy portion is completed. Care, of course, must be taken to reflect the tissue both palatally and buccally to ensure no iatrogenic damage from the drill during the osteotomy process. And our final 2.8 millimeter drill is introduced here to complete the osteotomy. Uprighted slightly to correct for a slight angulation distortion that occurred during the initial osteotomy. The final drill is replaced into the osteotomy site and a periapical film taken to confirm the final length and orientation in relation to the adjacent teeth roots. Once this has been done, the implant is removed from the vial. As you can see, the cover screw is enclosed with inclusive in the event that we decide to bury the implant and utilize a cover screw. The implant is then hand delivered utilizing the serrated carrier, hand torqued in until it shears off. Next step is delivery with the handpiece hex driver. This is allowed to rotate until the osteotomy is fully engaged and the driver disengages itself, as you can see there. Then the final placement of the implant is achieved utilizing the torque wrench, which will allow us to confirm our 35 Newton centimeters of initial stability that we're seeking. As there is a small amount of defect on the buccal there, the decision was made to augment the grafting in that area prior to suturing. You can see here the orientation of the hex towards the buccal, which becomes imperative for restorative, as well as confirmation that we are approximately 1 millimeter apical to the CEJ of the adjacent teeth, which is the ideal position for the implant platform. Once that position has been confirmed, the custom temporary abutment in this case is seated and hand torqued to 15 Newton centimeters. Once that's securely in place, the biotemp is delivered to confirm for contour, shape, contacts, etc. Once any necessary adjustments have been made to the temporary, the soft tissue is irrigated copiously underneath the flap to ensure no hard or soft tissue debris remains. And the papilla and flap is reapproximated on the adjacent teeth, leaving the site directly around the osteotomy still flapped. The cover screw for the custom temporary abutment is sealed, either with Teflon or in this case cotton pellet, and the biotemp is delivered with the temporary cement of choice. The reason for leaving the flap unsutured at this point is to ensure that we can remove fully any temporary cement that exists around the biotemp, which is imperative for the healing, proper healing of the implant and the soft tissue around the area. Once this has been done, the soft tissues around the osteotomy site themselves and the implant site are reapproximated and confirmed again to ensure that there's no residual debris from the temporary cement. And the final result is seen here. As you can see, there is some blunting of the papilla as a consequence of the preoperative status, but the hope is that the soft tissue contouring of the custom temporary abutment will allow us to regrow some of the papilla in that area to achieve a better aesthetic result.